It's my pleasure to be here and talk about risk reduction and prevention of dementia and Alzheimer's disease. And I will especially focus on the multi-domain interventions, precision prevention, and new findings from the finger and worldwide finger studies. I hope you can see my slides well. Perfect. So just first a reminder, dementia is indeed one of the most challenging public health burdens we have in the aging populations. You can see how fast the numbers are increasing. And this is not only happening in Western countries, but actually the increase is even more rapid in low and middle income countries. So we can really say that dementia is a global challenge and we need global solutions. And nowadays, we do not anymore talk only about dementia. We have luckily wonderful new biomarkers so that we can capture Alzheimer's pathology many years before a person develops dementia. And now we can capture the biomarkers also from blood. The field of blood-based biomarkers has been developing very fast. And if we are looking at persons who are at risk, who have amyloid protein in the brain, the number may be 10 times higher compared to those persons who have dementia. Luckily, not all of these persons who have amyloid in the brain will develop dementia. And here we have really the prevention potential. If we could just postpone the onset of dementia with 5 years, the amount of persons with dementia would reduce by 50%. And that's one of my key messages today. Dementia risk reduction and prevention is really the key to manage the global dementia epidemic. And luckily, we can say it's never too early to start to prevent dementia, but it's never too late either. There's always something we can do for the better brain health and better functional level. Well, what can we then do to prevent or reduce the risk of dementia? When I started my research career more than 25 years ago, we only had high age and the genetic risk factors. These were the only established risk factors for dementia, and there was not so much what we could do to reduce the risk. Many of you may know this beautiful Lancet Commission paper, which came out last summer. And the newest estimates are pointing out that at least 45% of all dementias are linked to modifiable vascular, metabolic, lifestyle, and environmental risk factors. So there is so much we can do to try to manage these risk factors. If we are looking at this list of risk and protective factors, there are many vascular, metabolic risk factors, as you can see, blood pressure, obesity, high cholesterol, but there are also some more novel or newer risk factors. For example, hearing and vision loss have been added to the list of modifiable risk factors. Here I would say we still need some new interventions and trials, and I'm happy to tell that we have just started a new intervention called HAHA, Healthy Hearing for Healthy Aging, trying to understand if a data-driven, more individualized hearing aid can indeed reduce the risk of cognitive impairment and what are the underlying mechanisms. You also see these novel risk factors. So it's not anymore only depression, but already feelings of loneliness and hopelessness have been linked with an increased risk of dementia, stress, sleep disturbances, and one of the newest one is impaired oral health, infections, and inflammation. So new risk factors are added all the time, and a lot of things are happening in this field. It has been more difficult to verify this evidence from epidemiological studies in randomized clinical trials. And what we have learned is that giving this long list of risk factors, we probably need to have multi-domain interventions, targeting several risk factors and mechanisms at the same time to get an optimal preventive effect. We have also learned that one size may not fit all. We need to better tailor the interventions to different risk profiles and populations. So we are really moving towards precision prevention. And that's what we tried to do in the finger trial, which I launched with my team already 2009. FINGER was the first randomized clinical trial developing and testing this multi-domain intervention component, targeting these 5 components at the same time: nutrition, exercise, cognitive training, social activities, and monitoring vascular and metabolic risk factors like high blood pressure, cholesterol, diabetes, and obesity. And this was compared to regular health advice group, that was the control group. These persons came from general population. They had increased risk for dementia based on some risk factors, but no clear cognitive impairment yet. The cognition was at mean level or slightly lower than could be expected for age. Intervention was 2 years, and now we are ready with 11-year follow-up. So we are learning a lot what are the more long-term effects of this type of intervention. Cognitive change was the main primary outcome after 2 years, and we could see that global cognition, all different cognitive domains, there was 25% more improvement in the FINGER group compared to the control group receiving regular health advice. And we could see the same pattern for all cognitive subdomains. Executive function, for example, the planning skills or multitasking, which is so popular in our societies today, 83% more improvement. Processing speed, how quickly and smoothly we can do different things, 150% more improvement. And even complex memory, 40% more improvement. So this is not only preventing or reducing the risk of dementia, this is optimizing brain health and all these domains which are very important for all daily activities. During the last years, we have been analyzing other outcomes, and there are many other benefits as well. The same model seems to help for other health outcomes as well. For example, the risk of stroke and cardiovascular events went down by 20%. And the risk reduction was even higher for persons who had already some issues with heart or for example, previous stroke. Quite strikingly, the risk of multimorbidity, developing 2 or 3 chronic diseases, was reduced by 60%. And we also saw that the FINGER group had better functional level. They could function better in activities of daily living, and they had less frailty and even better health-related quality of life. One important question is, of course, what is the cost? Can we implement this type of intervention, and can we really say that that can give some health economical benefits? And luckily, the answer is yes. We have been conducting simulations, and we have now even new results where we have been using the register data up to 8 years. And it was quite clear that the FINGER intervention reduced healthcare service and even the cost. There was less use of hospital inpatient care, emergency visits, and these benefits were especially strong among men. Altogether, around 4,000 euros less in the intervention group. And if we think that this target population is so big, you can add quite many zeros after this amount. And in that way, there is a huge potential for cost savings on societal level. Another question, which is of course important, is it's difficult to make long-lasting lifestyle changes. Is it really feasible? I would say yes. We have now data from the long-term follow-up after 11 years. And you see here the intervention group with red and the control group with blue. So after 2 years, when we had the intervention, there was a clear significant difference in the lifestyle changes for all these 5 fingers. And still after 7 years, the intervention group was doing better. And after 11 years, we could still see the differences among the oldest ones, those who were older than 70 years. So I would say if we manage to do something for 2 years, there seems to be long-lasting effects. And I have also some very new findings, which I will present later this year in a big Alzheimer conference. Those persons who were able to keep the healthier lifestyle up to 11 years, they also had better cognition. So it's still there after 11 years, which I think really supports the implementation and importance of trying to move on with this type of results. And why this is important? We know that many lifestyle risk factors are common, and we also know that there are new risk factors coming. We are the heads down generation. If we are looking at the numbers, how many hours we are sitting every day, 9 to 10 hours, all age groups, from children to older persons. So every step, every movement here really can help. And I believe, and we have evidence, that brain health can really motivate people to take the first step. What are then the factors why the finger model was successful? We have been collecting some of the main lessons learned. I think the finger model is quite pedagogical. It's easy to remember. Activate all 5 fingers every day. The group activity was very good. We included other persons. It gave social stimulation at the same time and also some extra motivation. But at the same time, giving individualized, concrete counseling was important. Very practical advice, how I can change, for example, my diet. Educated staff for all these 5 fingers, small steps, right timing, positive feedback, empowerment of own health, and also importance of community support, making the healthy choices the easy ones. After we published the finger main results in Lancet 2015, there has been great interest from other countries to adopt and further develop the model. And I'm very happy to tell that today we are having 70 countries from all continents who are part of the Worldwide Fingers Network. And altogether, there are already 20,000 participants in the ongoing and completed trials. And in this case, we can start thinking joint analysis. Can we use data-driven AI-based finger models? So this gives new opportunities to really have new kind of discoveries. And as you can see, we start to have also low middle-income countries on board. Africa Fingers was launched just before Christmas. I think it was in December. So it's very important to get also the new countries on board. And this is the, I would say, evolution of the Worldwide Fingers model. We are developing and optimizing the model all the time and also testing new target populations. So finger was for those who had increased risk, but I got questions from my patients. Is it too late? Can we still do something when you get the diagnosis? So that's why we have been developing Finger 2.0 and testing the same model for persons and patients who have early Alzheimer's disease with very good results. So that's why we can say it's never too late. And why not combine a lifestyle and pharma and test new technology, the concept e-fingers. And here we have a very nice results from a pilot study from Imperial e-finger print where we tested online finger, making it more scalable. And I also believe there is enough evidence to support implementation. And here we have just launched a new initiative, AD Riddle, where we aim to implement some of these lifestyle interventions and also blood-based biomarkers and new treatments when they are available. One example from the joint analysis from the Worldwide Fingers, why this big data is important. One important question is, of course, interaction between genes and lifestyle. If you have the risk gene, APOE4, can you still do something with lifestyle interventions? And the answer is luckily yes. We have now conducted meta-analysis in 3 countries, Sweden, France, and Japan, and it seems that APOE4 carriers are getting even more clear benefit of this intervention. And in that way, it may be a very important target group for different kind of interventions. And now we are expanding this research for other risk scores, polygenic risk score for AD and cardiovascular diseases. And it seems that the same pattern is there. Those who have the genetic suspectability may get more benefit from the lifestyle interventions. And finally, the next direction or the new direction, combining finger lifestyle with possible disease-modifying drugs, the precision medicine, give the right treatment for the right individual at the right time. And here we have the first trial ongoing, led and coordinated by Imperial College London. We combined finger with metformin, the diabetes medication, as a repurposed drug because it fit very well for this model and it was easily available. And the study design is quite exciting. We don't give metformin for all, but within the finger group, those persons who have increased risk for diabetes or that profile, they are getting metformin in different doses. And we also use ApoE4 enrichment so that at least 50% have ApoE4 carrier. And yes, you can see here, we are exactly on target. Now we have 54% who are ApoE4 carriers. And target is 600 participants. We have screened more than 750 and already randomized 340. So the trial is moving on very well. And we are using these readiness cohorts available at Imperial. So it's a very nice example how we can use the infrastructure. And this is my kind of vision for the future. Next generation of clinical trials and combination therapies, always starting with lifestyle and then based on the risk profiles. It can be metformin, it could be the new diabetes and obesity medications, GLP-1, and why not amyloid treatment if there are persons who have amyloid in the brain, or maybe triple therapy in the future. So like the cancer care is today, is kind of the combination therapy, which I believe is needed. And finally, just one slide about the importance of implementation. It normally takes 15 years to start to implement research. I think it's too long time when it comes to risk reduction. So we need to start creating the models. And I think prevention, no one can do it alone. We need to have collaboration between different stakeholders. So we are now updating our memory clinics to brain health clinics. We work with primary care with this e-fingerprint project at Imperial. We want to have the community involvement as well. And we have started to develop finger implementation networks. We have concept family fingers where we can involve the whole family, also caregivers, not only the person who has dementia or increased risk. And why not start even earlier when persons are at school or students? Then you can shape your lifestyle. And here we have the newest initiative, High Five for Life. And I'm very happy to tell that now Imperial College London students are having the first pilot to see how we can tailor the finger model so that it can really be fitting for this younger population. This is my final slide. And it just gives one snapshot about the AD Riddle projects, which I mentioned, a huge IHI project where UK London Imperial has a central role. And here, as said, we go from research to real life implementation, both when it comes to lifestyle interventions, blood-based biomarkers, digital biomarkers, and new treatments. And I believe Paris will talk more about this idea, so I thought that this is a good link to his presentation. My take-home action points are multi-domain interventions are effective and feasible. It's never too early or too late. We are moving to precision prevention, and the finger model can and should be further developed to different target populations and settings. And I'm very excited about the next generation of clinical trials where we can combine lifestyle and pharma and use new technology. And for the future, I think we should really have brain health as a priority, and we should work with implementation, both at individual and population level, and global collaboration is, of course, very important. At the end, I want to thank all the study teams and Worldwide Fingers teams and the stakeholders and funders, and thank you so much for listening.